We now begin with our first lecture of this session.
Our first lecture will be by Dr. Manisha Katikar, Madam. Patient is obese and that too morbid, posted for the spine surgery and that too thoracic spine. How to go ahead? Let us hear it from Manisha Katikar, Madam. I invite Dr. Sandhya Khond, Dr. Sangeeta Patil and Dr. Maruti Pawar, sir, to chair the session. Dr. Sandhya Khond, Madam, is senior anesthesiologist and teaching faculty at Noble Hospital, Pune. Dr. Sangeeta Patil, Madam, is the eminent speaker. Specific anesthesia interest is in peripheral nerve blocks, regional anesthesia, and USG guided nerve blocks. Dr. Maruti Pawar is experienced anesthesiologist and associated professor at GMC Satara. Now I request our chairperson to introduce our speaker.
Good afternoon, everyone. I have a great pleasure in introducing Manisha, and I'm really honored to be chairing this session because Manisha is the speaker. It's known to me from ages, and it's really a pleasure. No words can introduce whatever you see on the place. It's much, much less than what she deserves. I welcome you, Manisha, and all the best. Please go ahead.
Our dynamic Manisha Katikar ma'am needs no introduction. Welcome, ma'am.
Thank you so much. Thank you, respected Khond madam. It is you who taught me ABCs of anesthesia in the JJ hospital. And I'm privileged that you are chairing the session and I'm going to speak here as a faculty. I'm very fortunate and lucky for that. So the topic given to me, I hope there are PG students in the audience. How many of them are the PG students? Good number. Good number. Because this topic is really important for all the PG students. See, you can discuss morbid obesity. You will get to know lot of academic material on morbid obesity. But the topic that has been given to me is, even the introducers also introduced, it is morbid obesity and that too for thoracic spine surgery. So as far as this is concerned, this topic is concerned, a morbid patient is coming for thoracic spine surgery. And I feel when such kind of scenario is there, the problem is definitely doubled up. And you all also will agree to it that a patient coming for thoracic spine surgery is usually a complex surgery, and that patient, when he is morbidly obese, definitely the surgery is going to be, the anesthesia management is going to be super complex. So what are the anesthesia considerations for thoracic spine surgery in obese patients? As far as morbid obesity is concerned, we are always worried about the airway. We are worried about the ventilation. We are worried about calculating the doses of anesthetic drugs. We are worried about the complications like deep vein thrombosis as well as pulmonary embolism. And as far as thoracic spine surgeries are concerned, there are a lot of hemodynamic perturbations that occur in thoracic spine surgeries. We need to give the patient various positions like prone position, which is given most commonly, or if the lesion is anterior to the spinal cord, then transthoracic approach. For the transthoracic approach, we have to give the lateral position. So there are various implications of positions when we anesthetize the morbidly obese patient for thoracic spine surgery. Obesity is a disease, and how do you calculate obesity? It is calculated by a formula, that is body mass index is equal to mass in kgs divided by height in meters square. It has been now considered as an epidemic in 21st century which is affecting the younger population. It is a physiological dysfunction of human with environmental, genetic and endocrinological etiology. And who are the patients who can be labeled as obese patients? It is totally based on calculation by BMI. So, whenever you get an obese patient, it is especially for PG students, try to define in which class this obese patient fits. whether it is a class 1 obese patient, a class 2 obese patient, or a class 3 obese patient, because the definition only depends upon calculation of body mass index. The class 2 index patients, which we used to call initially as morbid obese, has been now labeled as class 2 obese patients in the newer classification, and patients who have more than 50 kg per meter square of BMI are now labeled as super obese. So what are the preoperative concerns in these patients? These patients who have morbid obesity, they come to us with multiple comorbidities, and the most important amongst them is diabetes, hypertension, and history of cerebrovascular accident, and they might have lipid profile which is really haywired. So we need to balance these special concerns when these patients come for anesthesia. Patient may give history of daytime drowsiness, patient may give history of hypertension, diabetes, patient may give history of snoring while sleeping. So this is all called as obstructive sleep apnea. And it is very important for all of us to diagnose obstructive sleep apnea in the preoperative period. It is a condition characterized by recurrent episodes of partial or complete airway collapse occurring during the sleep. It is done by sleep studies. The diagnosis is done by sleep studies by calculating the apnea-hypopnea index and by calculating the respiratory disturbance index. So these might be needed as far as the academic part is concerned. But what is more important as an anesthesiologist in the preoperative period is to screen the patients for obstructive sleep apnea by the stop bang questionnaire. I request all the PGs in the audience, if they have an obese patient to come for surgery and anesthesia, please include this in your pre-anesthesia checkup. Ask these questions because it has some clinical significance. These are very simple questions. It is divided into two parts, stop and bang. Stop, in the stop criteria, you need to ask the patient, you need to in fact ask the patient's relative, do this patient snore in the night? Do this patient feel tired, fatigued or sleepy during daytime? Has anyone observed him having obstructed breathing or choking or a gaspiration in the middle of the night and then getting up suddenly, opening the windows? Did you see this patient? If this patient is having higher blood pressure, and in the bang score, you need to calculate again the BMI. That is the most important. I am not very sure how many of the PG students here are calculating BMI if the patient is, if the obese patient is coming for anesthesia. Everything depends on BMI. All the anesthesia management depends on BMI. There are various calculators to calculate BMI. They are available on the Google. I request all the PG students, please download one of them and calculate BMI depending upon the body, depending upon the weight and height in meter square. What is the age of the patient? Another important thing, how many of you carry a tape when you are assessing the patient in the preoperative screening to calculate the neck as well as waist circumference? But it is very important as far as this population is concerned, this obese population is concerned, you have to calculate the neck circumference, and if it is more than 17 inches in a male or 16 inches in a female, it is a significant criteria. And gender, if it is a male, that is also a significant criteria. Initially, it was mentioned that score of 5 to 8 indicates moderate to severe disease. But now, the recent literature is coming and they have started telling us that if there are two criteria present, positive criteria present in STOP, and one criteria like BMI or the neck circumference that is present in BANG, then you have to consider that these patients may have increased chances of complications in the perioperative period. We are always worried about airway as an anesthesiologist. So, we need to find out circumference of patient's neck. We need to find out distance between mentum and upper boundary of thyroid cartilage. I think all the PG students know about the 3-3-2 rule. We need to find out extent of mouth opening and jaw protrusion. We need to check neck mobility. But as far as obesity and thoracic spine surgery is concerned, we have to find out presence of excessive adipose tissue in the cervical region of the neck, general features of patients of head and face. Why I am telling you this? Because many of these patients who undergo thoracic spine surgery, they come with neurological deficit, and the airway assessment is really challenging, or the airway management is really challenging in this group of patients. Obesity is a metabolic syndrome. Again, you need circumferences and some laboratory values to diagnose whether your patient is having a metabolic syndrome as a part of morbid obesity. You just have to calculate waist circumference, find out serum triglyceride levels, HDL cholesterol levels. You need to find out his blood pressure, whether it is hypertensive, his fasting glucose, and if the patient has 3 out of the 5 criteria, then this patient is having a part of metabolic syndrome as a part of morbid obesity. There is something called as obesity surgery mortality risk stratification score. It has been established for gastric bypass surgery or bariatric surgery, and it indicates again the same factors: hypertension, age, male gender, BMI more than 50, and any risk factors if they are there for pulmonary hypertension. But the recent advances are telling that this assessment tool is also found to be beneficial in assessing obese patients undergoing normal surgeries. A patient with an OSMRS scores of 4 to 5 should be closely monitored during surgical procedures. So as a preoperative consideration in these patients who are coming for thoracic spine surgery, we need to find out range of motions of cervical neck, we need to assess the restrictive lung disease, and along with that, we need to have clear documentation of preoperative neurological deficit is very important. That has to be mentioned in your pre-anesthesia checkup. And the most important thing is these patients who have injury above T6 or injury at a lower thoracic level, lower cervical level, may have autonomic hyperreflexia or dysreflexia if the phase of spinal shock is wearing off. So it is also important to ask specifically for the history of autonomic hyperreflexia. And how will you ask this history? Is the patient having palpitation? Is the patient having bouts of headache? Is the patient having high blood pressure? Is he been found to have high blood pressures intermittently? Any stimulus below the lesion, below the level of thoracic cord lesion or injury, a full bladder, some pinch or some injurious moment can create sudden bouts of hypertension in these patients who have thoracic cord lesions. So it is very important for all of us to know something about autonomic hyperreflexia or dysreflexia while anesthetizing these kind of patients. And as I mentioned, these patients have some kind of neurological deficits, and why we must mention about them? Because though they are obese, many a times we need to avoid succinylcholine in this group of patients because it can lead to hyperkalemia. So we have to be very careful in this group of patients. So what will predict a difficult airway in this group of patients? There will be increased amount of adipose tissue deposited all around the neck, which will decrease the size of airway. The shape of oropharynx becomes like an ellipse. Normally it is a circular with equal anteroposterior and transverse diameter. But when it becomes an ellipse, there will be more anteroposterior diameter than the transverse diameter, which will make not only intubation difficult, but also mask ventilation difficult. A neck circumference more than 60 centimeter increases the chances of experiencing difficult intubation. So along with this routine airway assessment, it is very important to assess the neck circumference. It is very important to give importance to this pad of fat in the area between the tip of the mandible and the hyoid bone. Also, we should know the difference between central obesity and peripheral obesity. A central obesity is higher abdominal or visceral fat deposition. So again, it is important to measure the waist circumference. A value more than 88 centimeter in women and 102 centimeter in men, or a waist to height ratio of more than 0.55 defines central obesity. And why this is important? Because there is release of various inflammatory mediators when the patient has central obesity. So what are the intraoperative concerns in this patient? The first and most important, when you assess the patient, you need to see for the veins. You may need an ultrasound or vein locator to find out the good veins in this patient, because it's a supramajor surgery. There might be blood transfusions or there might be hemodynamic changes. So you should have a good access if you anesthetize the patients for thoracic spine surgery. Positioning for laryngoscopy. There is excess of fat in the cervical region. It is obstructing. It is not giving you adequate position, the flexion at extension of neck and flexion at atlantoaxial joint. So something ramp up position. It is very easy. I think you should practice. All the teachers must be teaching you. But PG students, keep it in mind that you have to elevate the patient's head. The only aim is that you have to get the ear as well as sternal notch in one line by putting whatever you want to put. Maybe a head ring, maybe some folds of towels, maybe some prepared ramp positioning pillows. So whatever is there, but you have to do it that. In fact, I would like to tell you that you have to have a scale in your hand, which I do, and you have to see through that sternal notch and mastered external auditory meatus is in one line. So that is the most important message as far as intubation is concerned. Drugs doses, we don't know. What is the total body weight? What is the lean body weight? What is the ideal body weight? And what is the adjusted body weight? So we have to find out what is the drug dosages for this kind of patients, and when such patients come for you for surgery and anesthesia, you have Google on your social media on your fingertips. You need to find this chart. Which drug has to be given by total body weight? Which drug has to be given by adjusted body weight? Which drug has to be given by ideal body weight or lean body weight? So that has to be seen in the chart and that has to be followed. So what are the common thoracic spine surgeries which we routinely face in our clinical scenarios? These patients may have degenerative diseases. These patients may have traumatic compression fractures, which involves the dorsal vertebral body. These patients may have tumors. It may be intradural extramedullary tumor. It may be hemangioma, a very vascular tumor. It may be some kind of schwannoma or neurofibroma at a dorsal level. Patient can come for kyphosis or scoliosis. That is totally a different clinical scenario. And these patients may have infection at one of the dorsal levels. It may be a tuberculous infection, but it is compressing spinal cord. It is causing deterioration in the patient's neurological power. It is causing involvement at bladder and bowel, and these patients may be having severe pain. These are the indications for surgical intervention, and these patients come to you for anesthesia. They are paraparetic, their bladder and bowel is involved, and you have to manage such kind of morbid obese patients for surgery. I would like to discuss a case which I did recently, 2 months back, a patient who was morbidly obese and who came for surgery. It was a degenerative disc disease. He was a 64-year-old obese patient who fell from a bullock cart and was brought to our hospital with paraplegia. He had sensory level T8 and there was involvement of bladder and bowel. MRI revealed traumatic disc prolapse with compressive myelopathy at 2 levels, D2, D3 and D9, D10. Neurosurgeons told me that we'll have to do decompression, we'll have to give prone position, we'll have to do decompression at both the levels. This patient had already developed paraplegia. It was a traumatic disc prolapse. He was weighing 110 kg. That was the answer given by patient because it was difficult to calculate his weight. His height was 160 centimeter. Waist circumference was 94 centimeters. I calculated BMI. It was 43 kg per meter square. He had a poor effort tolerance. He was unable to sleep in supine position and preferring recumbent position. His staff back questionnaire score was 7. He was diabetic, hypertensive, which was well controlled. His ECG was normal. X-ray showed cardiomegaly and 2D echo revealed mild concentric hemorrhage. Cardiovascular assessment is very important in this patient as they tell us about the pre-existing cardiac conditions. These patients are prone for various type of arrhythmias. They may get atrial fibrillation, they may get ventricular tachycardia, they may have systolic or diastolic dysfunction, they may have pulmonary hypertension. My patient had a room air ABG with PaO2 of 65, PCO2 of 47 with oxygen saturation 95% on room air. And why this is important? We have to do ABG at room air. This is because if the patient has arterial PCO2 more than 60, then these patients are going to have increased risk for experiencing the complications. Pulse rate was 64 minutes, BP was normal, Malam patti, again we have to assess that also. It was class 2, mouth opening was adequate. The patient had short neck with neck circumferences of 42 centimeters. There was a thick pad of fat all around the neck. I optimized the patient with whatever time that was a surgical emergency or a semi-emergency, but I needed some time for optimization. chest physiotherapy, incentive spirometry, nebulization with acetylene, steam elevation, deep breathing exercises, and sequential compression of devices for DVT all were offered to the patient along with DVT stockings. The simplest test which you can carry out bedside is the breath holding test. You do a breath holding test initially when you see the patient and offer him all this physiotherapy treatment, and then again calculate his breath holding test. That will definitely give you some idea that his parameters have improved. Pre-oxygenate these patients well as they desaturate more frequently, more quickly during apnea. They have reduced FRCs, so they develop VQ-mass mismatches which can result into hypoxemia. They have large tongue, narrowed airways, and therefore they have, in addition, OSA. Therefore, it is difficult for them, for us to secure an airway. You give an upright position where you are pre-oxygenating the patient, while when you are making the intubation attempts, give passively administered oxygen to them, and that is very important. Why? Because these patients desaturate very rapidly, and that has to be remembered. I pre-medicated my patient with fentanyl and glycopyrrolate. These patients they have GERD, that is gastroesophageal reflux diseases, so you need to give something to prevent nausea and vomiting. You need to give, as I said, central obesity is associated with release of inflammatory mediators, so you need to give prophylactic antibiotics for spine surgery. I induce my patient with propofol 2 mg per kg, a very well titrated dose. You can use thiopentane sodium, etomidate. These drugs are highly lipophilic, so their levels rapidly decrease from blood. I was able to ventilate the patient adequately, but you have to have LMA or in fact fast track also with you when you are inducing such kind of patients. I intubated my patient with vacurinium, avoided succinylcholine as the patient had paraplegia. Madam, 5 minutes please. I am about to finish. Intubated with VLS with flexitive 4 blade. Modified Cormac-Lehane was grade 2, intubated with 8 mm cup flexometamlic tube. Ventilated them adequately, and if you do not have much accessories, but then you should have flexible fiber optic bronchoscope as well as video laryngoscopes available with you when you are intubating this kind of patient. The use of curved blade of video laryngoscopes are very helpful in intubating such kind of patients, but you need to be very careful as the female patients may have excessive or the breast tissue, and you need to be bothered about that. Anesthesia was maintained, the patient was given proposition, all pressure points as well as eyes were padded with cotton roll and closed properly. Gel hover support was given. Patient was maintained on oxygen, nitrous, sevoflurane, dexmedetomidine infusion, and ventilated adequately, monitoring the end-tidal CO2. When we are giving other drugs like remifentanil, which can be given with the help of total body weight, we have to see through it that these patients, when you give the drug doses that has been mentioned with total body weight, may have supratherapeutic plasma concentration, and they have increased risk of bradycardia and hypertension. What about inhalation agent? Isoflurane, sevoflurane, desflurane. Desflurane is least lipophilic as compared to isoflurane and sevoflurane, and therefore it is best choice for anesthetic induction in morbidly obese patients. These patients, remember that they have a protracted volume because of prolonged fasting, increased urine output secondary to antihypertensives and hypoglycemic agents, and because there is a problem in going to the washrooms, their oral intake for water is usually less. So goal-directed fluid therapy, we had excellent lecture from madam, has to be considered in this patient. The next important thing is that we need to know what are the occasions where the patient is going to have a fall in blood pressure or rise in blood pressure. We have to be very careful during induction and during positioning when there can be sudden drop in blood pressure, and we need to manage that with IV fluids and inotropes if required. There can be sudden rise in blood pressure during surgical manipulation when the neurosurgeons are handling dura mater. So this is called as cervicogenic hypertension, which has been seen with patients with lower cervical spine surgery or upper thoracic spine surgery, and as I mentioned, autonomic hyperreflexia. Along with routine monitors, you have to have, if the surgery is delayed or surgery is going on for prolonged periods, you can monitor ABG, serum electrolytes and blood sugar. You can monitor neuromuscular monitor, or you can have a BIS monitor also. I reversed my patient with Sugamadex, that is a wonderful drug now available for obese patients, as well for undergoing thoracic spine surgery. The reversal of neuromuscular blockade with the use of neostigmine has been found to be delayed in obese patients. So operative procedure for my patient lasted for 3 hours, and I gave post-operative pain control with multimodal anesthesia, and the patient was discharged on day 7. So when we are managing such kind of patients, first thing we need to know what are the patient's comorbidities. Is he diabetic? Is he hypertensive? We need to carry a tape with us to measure the neck circumference, to measure the waist circumference. We need to classify the patient in the obesity group, whether it's a class 1 patient, class 2 patient, class 3 patient, or a super obese patient, depending upon the value of BMI. So we need to know what is the BMI of a patient, which can be calculated by very easy formula. We need to calculate his OS-MRS score. We need to know what kind of position the surgeon is going to go, what kind of surgical procedure that patient has to undergo. So we need to know, we need to see the MRI, we need to discuss with the surgeons, and
Madam.
we need to find out if there is, last word, if there is a requirement for any other extra things like if the patient is going to need massive blood transfusion or not. And we need to find out OSA. So with this background, I think the topic was extensive, morbid obesity and thoracic spine surgery, but I tried to cover up the important points. I'm thankful to Chairperson for giving me some extra time. Thank you so much.
Excellent talk, ma'am. Ma'am, I want to ask one question, ma'am. While shifting the patient, can you use nasopharyngeal airway after extubation?
Yes, we need to keep the airway patent. So whatever is required, why only naropharyngeal, even oral airway? The airway should be kept patent, proper position or extension to the neck must be given. In fact, if you see that there is still obstructive sleep apnea after extubation, you can continue the ramp position even in the intensive care setup also.
So really very fat topic, and ma'am has engaged within a time, try to engage. Let me tell our PGs, so this is the only single topic. It will cover your 5 to 10% of your MD curriculum portion. So such a huge topic, and madam has given a clear take-home message also from this short but rapid topic covered. So I wanted to know what is the extubation strategy, madam, in these patients?
Yeah.
In on table or in ICU?
Yes. I usually, we have now good drugs available with us. And the most important thing is, in last 6-8 months, we have Sugamadex also available with us. And we are using neostigmine for years together. We are not monitoring trough. Teachers like Khon madam has taught us how to balance the dose of muscle relaxant at the end of surgery. So we are titrating the doses of muscle relaxant. So it is always better to extubate these patients on table. But then everything depends upon the surgical scenario. What has happened during the surgical course? How was if there was a massive blood transfusion, if there are no untoward events, there are no hemodynamic perturbations intraoperatively, then it is always better to extubate the patient on table. If not, if the patient has undergone a major transthoracic approach for the surgical excision of some anterior lesion and patient had massive transfusion, the duration of surgery was extended for a longer period, then such patients can be ventilated in the ICU setups.
Another examiners or PG's point of view, the favorite question was what about wake-up test intraoperatively?
Yes.
And monitoring also. So how it is evolving nowadays?
Yeah, since the topic was vast, I did not mention about wake-up test, but now there is something called as intraoperative neuromonitoring. The wake-up test, I think, is now outdated, and we are routinely monitoring somatosensory evoked potentials or MEPs, and that helps us to diagnose any kind of neurosurgical insult if the neurosurgeon is doing so. It is always better to avoid wake-up tests in such kind of obese patients because it is really difficult to manage the perioperative part or the part of the anesthesia after the test is done intraoperatively.
I would like to know about, you talked very well about the OSA, that is a very accompaniment and a common feature. But I would like the students also to note one thing. They were talking about the apnea, hypopnea index, which is routinely done, which very easy to do. But one good thing that the criteria that you drop of SpO2 by 4%, which is cut off, or more than that, is taken as counting the index. But what about the incidences where the cutoff is crossed? Those are not counted. So all or none, all above 4 also will be counted, which is not physiological, which is not, because you probably are underestimating the risk. So may I suggest, for morbid, yours is a borderline, but for morbid obesity, or BMI 50, insist on polysomnography, which will pick up all the incidences of drop in SpO2, no cutoff of 4, that's one thing. So please keep this in mind when you're adding up to a matter on obesity, that's one thing. Second point that I would like to ask, discuss about, just now we heard about the goal-directed therapy and the fluid responses of number of segments that are massive blood loss and massive fluid shifts that have occurred. So what do you have to say about the responsiveness to fluid challenge in these patients, especially in prone position?
Yeah, that is why I said, madam, the goal-directed fluid therapy, we have to replace blood to blood. Whatever blood loss is there, and otherwise, if you see, look at the hemodynamic response of the patient. If you practice goal-directed fluid therapy in these kind of patients, it is really helpful.
You said protracted volume.
Yeah, because there are two schools of thoughts, either to go for restrictive fluid therapy or goal-directed fluid therapy. So I prefer to practice goal-directed fluid therapy in this group of patients.
Okay.
Thank you, ma'am. It was
Thank you so
clear.
much for giving me to share my views. Thank you so much.
Yeah. And along with
Thank you,
the sleep
Mrs.
studies, we can go ahead with nocturnal oximetry also. That has been also found to be very useful to find out apnea, hypopnea indexes.
Thank you, madam. It was a clear, crisp, and lucid talk.
Manisha madam, it was very good and fantastic presentation, and really what PG conference need, this is the presentation you have done. And most important thing, only she had not given the information, but at the same time she had given used the application of knowledge what she had given on the patient. So best madam, thank you.
Now I request chairperson to felicitate our speaker. And now I request Dr. Manisha Patil madam to escort the chairperson to felicitation point. Dr. Vinayak Patil will felicitate the chairperson.